Hello, my name is Jorge Cortes from the Georgia Cancer Center at Augusta University. And I want to discuss with you one important topic, which is the outcome of patients who receive several FLT3 inhibitors. Today, we have more FLT3 inhibitors, some already approved, at least in the US. There is midostaurin and there is gilteritinib. We have had sorafenib available, although it's not approved for this indication, and there are several other FLT3 inhibitors under investigation. And although they have slightly different indications, in the end, many patients who receive one FLT3 inhibitor may develop resistance, and we want to use another FLT3 inhibitor. And the question is, how likely is it that this patient may respond to that subsequent FLT3 inhibitor? And there were some studies that addressed this particular question at ASH recently, 2020. And I want to highlight a couple of them because they approach this question slightly differently, but they provide valuable feedback. One of them looked at a large series of patients treated at a single institution where patients that had received any type of FLT3 inhibitor, and some of them as frontline, some of them as salvage, and then they were followed as they received further therapy, and many times with another FLT3 inhibitor. So the patients were divided into those who received the FLT3 inhibitor as frontline therapy, and those who received their first FLT3 inhibitor already as part of their salvage therapy, meaning they had received frontline therapy without a FLT3 inhibitor. So if we look, for example, at those patients who received the frontline therapy with a FLT3 inhibitor, it was very evident that the probability of response decreased significantly as they moved to a second and then to a third FLT3 inhibitor. So with the first FLT3 inhibitor, the response rate, again, this was frontline therapy, it was in excess of 70%, and it dropped to the 30% range when they received a second FLT3 inhibitor. It is also important that the response rate was much better if they received the inhibitor in combination with other agents rather than as a single agent. And the same was seen in patients who received a FLT3 inhibitor, their first FLT3 inhibitor as a salvage strategy, where the response was 45%. And then when they received a second FLT3 inhibitor, the response dropped to about half, about 20%. Once again, the response was better if they received the inhibitor in combination with other agents rather than as a single agent, whether these other agents were high intensity or low intensity. These response rates also matched the probability of survival, where there was a significant drop, for example, in the frontline setting, from a median survival of 16 to 17 months with the first FLT3 inhibitor to around 6 months, and then less than 2 months with the second and third respectively. And in the salvage, when they received the first FLT3 inhibitor in the salvage setting, it dropped from 7 to 8 months in the first inhibitor to around 4 months with the second or subsequent FLT3 inhibitors. So these analyses suggest that there is a significant decline in the probability of response of patients and the overall outcome when you move to a second and a third FLT3 inhibitor. A different analysis came from specifically the studies that used gilteritinib in patients with AML FLT3 mutated. And all these studies were done in the salvage setting. The gilteritinib was used in the salvage setting. And they pulled data from 2 different studies, the Chrysalis study, which was their initial dose escalation study, dose finding study, and expansion phase 2 study, and then the AML study, which was a randomized therapy, the pivotal trial comparing gilteritinib versus standard chemotherapy. And they focused particularly on patients that received a dose of at least 120 milligrams of gilteritinib to 200 milligrams of gilteritinib. And what they found here was slightly different. They focused on the patients that had, among their prior therapies, received some FLT3 inhibitors. And they did have a subset of those patients. In the first study, there were about 30 patients and in the second study with gilteritinib, but also about 30 patients. In this context, what they found is that the response rate was very similar, whether the patients had received a FLT3 inhibitor or not. So, for example, in the Admiral study, the 30 patients that had received a prior FLT3 inhibitor had a CRC, a composite complete remission of 48%, compared to 55% for those patients who had not received prior inhibitors. And in the Chrysalis study, the response rate was 30 to 50% with prior TKIs in the different doses, and it was about 40% without prior FLT3 inhibitors, so not very different. So what's the difference between these two analyses? And I think one of the obvious explanations is that in the second study that I described, every patient received gilteritinib as their subsequent therapy, and we know gilteritinib is a very potent FLT3 inhibitor. It's shown very significant efficacy, whereas in the first analysis, it was a pooling of any FLT3 inhibitor. And we know that not all the FLT3 inhibitors may have the same potency, the same efficacy, the same response to the different mechanisms of resistance, particularly different mutations. It makes a difference whether it's a type 1 or a type 2 inhibitor, et cetera. My conclusion of this is that certainly on a patient who has received a prior FLT3 inhibitor, if they have demonstrated the persistence of the FLT3 mutation upon resistance, it is definitely worth using a subsequent FLT3 inhibitor. Now, I did mention it is very important to document that there is persistence of the FLT3 mutation, because we have also learned that some patients develop resistance based on the emergence of alternative clones that do not have a FLT3 mutation. And in that setting, you would probably treat them differently. Now, would I reserve the most potent FLT3 inhibitor for subsequent therapy? Definitely not. I would use my most potent strategy up front to minimize the risk of that patient relapsing. And then if the patient eventually does relapse or develop resistance, then I would use the best that I have available of those that are remaining. But I never reserve my better choice for subsequent therapy, because in a cancer patient, the best probability of response is the first attempt that you make. So that is what I saw at ASH regarding this important question. I hope this is useful, and I thank you for your attention.